Okay, it is 2 after, so I may as well start, right? Even though it's summertime, I know summertime often these kind of rotations and talks decrease. So glad to have people join online and in person. So welcome to Public Health Grand Rounds. This is the second in our series, and it's intended to be a time to have me talk to clinicians. I'm Leisha Nolen. I'm the Utah State epidemiologist. And so my goal is to really try to get public health information back to clinicians so that you as clinicians have some idea of what's happening in public health and maybe use some of that to think about how you're treating patients, what you're doing in your clinics, and what you're doing. So the goal is to do this twice a year. The next in the series will be in November. Um, I will say we accidentally sent out an echo invite that had the recurring date like already set, and those were not correct. So if you have this in your calendars, please delete that reoccurring one. We'll send you a new one each time when it comes up because it turns out if you do every 6 months, it doesn't work out from me being able to do it in real life. So look for, if you have those invites, you should probably be able to see them in your calendar on November 13th at noon. Delete that one and the rest in this series so that you don't get these confusing invites, and instead we'll send you new ones for the actual date. But here on the screen, I'm showing you a QR code where you can sign up so that you get the actual real invites each time. So we will send you in, if you sign up for that, we'll send you announcements so that you are ready to go at the real time. And sorry for those people. I think a few weeks ago, some people joined the one that was the air invite, and I'm sorry about that. But so this is, yeah, this is a program that the Department of Health and Human Services is doing, and happily the ECHO program, which is a program at the U to do training across the state, has helped us work on this. They are providing CME for this, so you can get CME for this and then future sessions. But happy to have you all join, and hopefully I will give you some information that will be useful in your clinical world. Um, so today's agenda, first we're going to talk about highly pathogenic avian influenza, then syphilis, then asthma, and then I'm going to do a surprise topic because I always get to have the surprise topic come to me on a Friday afternoon. So I thought I'd give you all a surprise topic at the end of the talk because that's what public health actually really is like. So first, highly pathogenic avian influenza. So as the name implies, this is bird flu. It is the avian influenza that birds get. And it is just like all of our flus, they spread as common infections. And there's two types. We've divided them into two types. We divide them into low pathogenic avian influenza, essentially the bird cold, really common, fairly mild, but it has mutagenic potential. So it's always something that sort of like the international community watches, but doesn't do really much about at all. The things that people worry about is the second type of avian influenza, and that's highly pathogenic avian influenza. And this is bad. They often see that when this virus gets into flocks of birds, 90% of mortality in 48 hours. So this is not a human flu at all. This is a really, really severe flu. And so this is something that we do see go through the country fairly frequently. We had a really bad wave of it last year. You all probably noticed your egg prices went up last year. That's because of highly pathogenic avian influenza went through and killed off a lot of our birds. But so this is what you probably have heard about this in the news. And so we hear a lot of things about highly pathogenic avian influenza. And the thing that drives me nuts is it is named because of its effect in birds, right? It's highly pathogenic to birds. But I think when we talk about this in news and to the population, it sounds worrying because it's highly pathogenic and people ignore that avian part. So it is named for the effect in birds, not necessarily effect in humans. But it is still of concern because we know flus can mutate and cross between species and cause people to get sick. So that is why we're worried right now. So before I go into avian influenza more, or what's happening right now more, I'm going to talk a little bit. I'm going to do a refresher for all of us on how we name influenzas because probably you all have forgotten. I always have to remember what the heck we're talking about when we hear these N's and H's. So all flus are named on a convention where it's an H number, N number. So H is for hemagglutinin. It's one of the proteins on the surface of the virus that actually allows the virus to bind to the human cell. And the N is neuraminidase. It's another protein of the virus that allows it to break open the human cell after it's made all its little baby virions and explode and spread virions everywhere. So we have these two different proteins, and that's how we name it, is what kind of proteins the virus has. So it turns out there's 16 different H's and 9 different N's, at least at this time that we know of. And if you imagine all those can combine with each other, so you can get tons of different combinations of H's and N's. And so you have many different potentials out there. So of course, the thing we care about is when these things get into humans, right? That's what we really care about. And so there's 3 main ones that have been in humans that at least we know of, that we've had occur recently. And one is H7N9, then H5N6, and H5N1. So H7N9 was first detected in 2013 in China. It actually had quite a few human cases, 1,500 cases between 2013 and 2018, with 2016-17 being its big peak year. And it was pretty severe, 39% fatality rate. And I will say for this fatality rate and all the fatality rates here, and actually probably most fatality rates we ever think about, it's probably slightly inaccurate, right? Because we are telling you how many people we die that we know about. And just like with any infection, we're going to have the people who are probably not sick enough to come into the hospital. And even those that are into their primary care clinic, they might not get tested. So we probably are detecting a lot. We're missing a lot of mild infection. But it's still useful to look at what our fatality rate is when we see people who actually come in and people we actually diagnose and how many of them die. So I think it's useful to think about this as sort of a proxy, like, oh, this is worse than the other, but it's not an absolute number at all. But 39% fatality rate would be considered very bad. There's very few infections that are in that range. And when we see that range, we are concerned. The other strain that's been circulating that we know of is H5N6. This was, again, came out of China in 2016. It was much more contained. It stayed in the Western Pacific, got about 90 cases that we knew of. And again, pretty similar fatality rate. But the one that's more interesting is H5N1. You've probably heard that combination of numbers, and it is the strain that is currently circulating. It's been around for a while. It was first identified in 1997 in Hong Kong, and it's known to be endemic, or meaning it's always in birds in Asia. But it's really made the hop, at least that we know of, into humans in 2003. Since then, we've had 909 sporadic cases in 23 different countries. All those cases have been people who've had really, really close contacts with birds. So they're generally poultry workers, or in places with lower income, people who really have their birds right in their house. There have been a few times where it went actually human to human. So not bird to human, but human to human. That's something we always watch for, because that's what makes us worry. We're not going to have the next pandemic because we all get exposed to birds, right? That's not going to really be super worrying. I don't get close to many birds myself. I don't know if you all do. But the worry is when it starts going human to human, because that's when we can actually have a pandemic. So we've had a very few cases where it did spread human to human, but this is extremely few. I think it's like 3, where it was essentially a father to a daughter or somebody in a household. But then it ended and didn't go any further. This one has a 52% fatality rate. So 39% for the others, 52% for this. So this does seem like a more severe disease. So it certainly is of concern. This circulated quite extensively for the last few years. This is the one that killed all our chickens and caused us to pay more money for our eggs. It was around in 2016. It reappeared in 2022 and has really been circulating since then. They report that we've had 1,144 outbreaks, which means different like farms and areas hit, with 92 million birds. Utah last year had quite a few hits. We had 21 commercial flocks that were hit, and 10 backyard flocks, leading to 2 million birds. If you ever run a good story, sometime you can ask our team about culling these birds, which of course is the nice way to say killing all the birds on the farm. There were massive farms that had to kill all their birds because of this. And it's quite a dramatic procedure. But that was last year. And in birds, and it turns out birds is the name of this virus, but it can go to other animals, and that's what we're always worried about. So it turns out we found H5N1 in many different animals. I love this list here. We get the coyotes, we have skunks, we even have things in the animal, right, in the water, right? We have where is it? There's seals, there's also river otter. I mean, it's just a wide variety. So this virus is starting to affect a lot of different animals, and you can see it's really across many parts of the country. So it's bouncing out of birds and into these other animals, which always makes us worry. And then what made the news, and what probably if any of you have heard of this, is because it now has made it to cows. So in March of this year, there were cows in 3 different states that had this weird unknown illness. They didn't know what it was. They went and did like a panel on it and said, oh my gosh, this is H5N1. And so that's when we first identified it. Since then, we've had it spread to a number of different states. The most recent data on the USDA website shows these different states. I think it's quite impressive how it's sort of surrounding Utah, but we're not in Utah yet. But we have a number of different herds throughout the country infected with this. And then the next step of the worry was that we get to the point where we actually found it in the milk supply. FDA found this virus in milk in April. It found it in milk that was from a number of different states. It did correlate with the states they knew animals were infected in. And it was shown to be the same virus. What they did find, though, is this is a virus. They were doing PCR, which means they can find small pieces of DNA. It doesn't mean an actual live virus. And they were found in pasteurized milk. It was just these small pieces. The concern, however, is that it is in raw milk. It is not destroyed. So we do have the possibility of live virus in raw milk. So for people drinking pasteurized milk, it is not a concern. But for people drinking raw milk, we have a slight concern. So then next step is we get some human cases. We did actually have a human case last year in April that somebody got it from birds. This was in Colorado. One of the people who was killing off the flock came down with pretty mild symptoms, was tested positive, got Tamiflu, got all better. And it really looked because they were so close in contact with these birds that they got exposed. But then this year, we've now had 3 people test positive, and those were people who were working with cows that were infected. Interestingly, they all had conjunctivitis, which as a clinician, I should have said in the beginning, I'm a pediatrician, so I somewhat think of these in this way. But I would have never thought to test somebody with conjunctivitis for influenza. And I think the only reason this happened is because they were so hypervigilant that these people were in these barns with these animals that were known to be infected. So they tested them. 2 of them, the only symptoms they really had were conjunctivitis. With the third one, it did have a mild cough. All of them had super mild illness. And so still looking not too significant. So the question becomes, of course, should we worry? Like, is this scary? Is this the next COVID? What are we doing here? I am on the side of no. I am not worried yet. And the reason I'm not worried is right now we do have some human illnesses, but they're very mild. They're very rare. They are definitely in people who are very close contact with animals. And they really don't seem to be, and then we don't see a passing person to person. I also am not so worried because the data from the virus, when they've taken this virus and sequenced it, it doesn't have mutations that look like it should be able to bind well to human cells. So you can look and have predictions of what receptor bindings are going to really do well. And this virus does not have it. So not too worried from the genetics standpoint. And then treatments, if it does start to get bad, luckily we do have treatments already on hand. Tamiflu does work against this virus. They've shown that in laboratories. So if we did start to have this actually causing human disease, we have a counter agent for it, which is very nice. And we do have a long history of making vaccines for flus. And this isn't anything novel in terms of like how we would make a vaccine. We just need to switch what is included in our vaccines to cover this. Right now, that's not occurring. Instead, we're targeting the ones that we know are going to be our seasonal flu. But if we needed to, we could switch our production chain over to make vaccines to target this. But of course, I should say there is a reason to be slightly aware of this. I think there's a reason we're hearing about it, and it's because it is spreading. It is in so many animals. Why would we think humans would be totally exempt? So I do think, and I think this is reasonable, that this is going to continue to evolve, and it very well could continue to evolve to get to be more transmissible in humans. And we know that influenza virus is exceptionally good at recombining with other viruses, and that's where it gets worrying that this virus that's been in birds and then cows might get to humans or might get to some other animal like pigs, which are classically known to be a good recombination site, recombine and become a more virulent virus. So I think right now I'm not too worried, but I do think there's the potential out there that things could change. And so I think it's appropriate to keep watching. And I also think it's appropriate to do some precautions. Now, that image is not the precautions I'm suggesting. That's just, the extreme side. If we were in a movie, that's what we'd all be doing. But I do think we should do things like we should try to control the animal infections, monitor them for symptoms, try to keep it so it doesn't go herd to herd, so we don't get bird flocks affected extensively, different ways to prevent that. I do think it's good to limit the spread to humans, right? So when we have people working with infected animals, we try to protect them as much as possible. Do eye protection, gowns, masks, gloves, monitor for symptoms. I do have a concern about raw milk, and a ton of people being exposed to possible virus in raw milk is worrying. And then I do think it's reasonable to have some clinical awareness so that we do watch for human infections and make sure we don't have some infections that we start popping up that we didn't realize, and instead be on top of them as fast as we can. So what are we doing at the state? So in the Department of Health and Human Services, we are working extensively with the Utah Department of Agriculture and Food, who is really in charge of our dairy and agriculture, so birds and cows. And they are really doing right now a monitoring of the milk to see if there's any signs of infections. They have an algorithm where they have these general signs of infections they look for, and if they see that, they'll go on and test specifically for this virus. They're also working with farms to really educate them about how to watch for signs in cattle in case there's any sick cattle to be able to be reported. And then we're doing things at our level at the human side. We're doing things where we're tracking the number of people who come into the emergency room for influenza-like illness. This is our way to capture things that are undefined. We have an influenza-like illness, which is a really broad system, so it doesn't depend on testing, but instead depends on symptoms. So we're watching that to make sure we're not seeing blips in that. We're sequencing any influenza samples that are untypable so that we make sure that if there are unusual viruses out there, we know what they are. And then we also are working with CDC where we send them a certain number of samples each week so that they, flu samples each week, so that it's done in a statistical way so that we know if there is actually H5N1 in a human who comes and gets tested, we have a 95% chance of catching it in that sample. Sorry. So these are the good precautions to really just keep an eye on what's going on in our state and what's going on in the flu that is around. Also, we are lucky here in Utah. Salt Lake County is part of a special grant where they do really intensive investigations of all people hospitalized for flu in their county. And so they do these really in-depth investigations, and they actually sequence the samples of all people who are hospitalized for flu in Salt Lake County. So we have really good data coming in from that part of our state. So that was without animal cases. If we start to have animal cases, we're going to get more aggressive about this. So we've been talking about the Utah Department of Agriculture and Food about the steps, and really it's going to be two-tiered. We're certainly going to do a lot of education, push out a lot more education to farms and to clinicians. But the main thing is we'll do is if we know there are farms with sick cattle, we'll have people monitor themselves for symptoms. If we start to see more signs that it's cause actual human disease, we'll do more active monitoring where we actually call them and check on them ourselves. So that's what we're doing. But what do we want you as clinicians to do? First, we just want you to be aware of unusual cases. We always want you to be aware of unusual cases, no matter what it is. But we want you to keep track of, like, if you do see a lot of cases of influenza while it's summertime, We would like to hear about that. Certainly, we do have sporadic flu all year round. It is possible, but if we have more than what you feel is normal, we are always interested in hearing from you. We'd also be interested in hearing if you're seeing more severe infections or unusual infections with influenza that you just seem unusual to you. We'd be interested in hearing that. And then certainly clusters of cases. If you're used to seeing, one or two flu cases a week and you suddenly have 5 in a day, we'd love to hear about that. And if you do see these unusual cases, we'd ask you to sort of do a little few questions to see if there are exposures that would suggest it's an animal source. So were they around birds? Were they around cows? Did they drink raw milk? And then the last one, which I think is actually a little amusing to have to say, is we'd love to have you talk to people about the risks of drinking raw milk. I find it kind of ironic that maybe something like influenza would cause people to reconsider drinking raw milk. We know raw milk consumption is really popular in Utah and very, really entrenched in law. But we know raw milk is very risky. There's a lot of different bacteria that routinely are in raw milk. But it would be kind of ironic and amusing that if people change their behavior because of high pathogen avian influenza. But I think this might just be an opportunity for clinicians to talk to their patients who drink raw milk and just remind them not only of this risk, but all the risks that go along with raw milk, so that we could maybe have people protect themselves for many reasons. I will say, if you do ever suspect a case, we would encourage you to get a respiratory sample. Make sure you protect yourself with PPE. You could start the person on empiric antiviral treatment if you think that's the person is clinically appropriate. We'd love you to contact us, let us know that you are worried about it. And then to certainly have the person try not to infect others by staying at home away from others. And so another thing you could do is sign up for our Hans. So we at the department have a specific email alerts that go out when there's something unusual going on. They're called the Utah Health Advisory Notifications. We usually call them Hans. CDC also has a Hans system. We amplify those. These are emails that we send out very selectively about things that are of concern. We send probably 2 to 3 emails a month, so it's not going to overwhelm your email box. And we usually try to take the ones that are, if CDC sends out ones that are only for Puerto Rico, we don't send those out. But if it's something that's relevant to our state, we send that out, and we usually try to add in the Utah context so you can think of how it affects your patients. But QR code, I'll show all these QR codes again at the end. So if you don't have time, you can sign up through those at the end as well. So with that, I will move on to syphilis, which is unfortunately an infection that has taken up a lot of my time, I'd say for the last 10 months, which is really unfortunate because syphilis is actually one of our really successful public health actions in the last half a century. So here's the rate of syphilis cases in the United States from 1941 to 2022. You can see it was very common back in the 1940s and really plummeted with the advent of antibiotics and interventions. But sadly, we are at the end there where we see this like going back up. And in fact, in 2022, we had the highest number of syphilis cases reported since 1950. So we are going up. And if we look at this, the graphic from CDC, where it shows the increase in cases, you can see it slowly gets darker and darker across every state, showing that it is really becoming more common. Utah is a little light blue, right? We're not quite so dark as everybody else, but you can see, and we are just, we're just a little behind in the trend. So we are starting that. And we certainly have neighbors who have a lot of syphilis around us as states. If you look at our actual numbers here in Utah, so the purple is the US, the teal is Utah, you can see we are below. We are usually, this is pretty typical for us, we're often behind the curve and a little below, and especially for things like sexually transmitted infections because of our practices in Utah. But you can see we're following the trend. So we are going the same way as the rest of the country. One thing that is definitely notable is that we are starting to see more female cases. So if you look back before 1995, the differences between men and women in syphilis weren't hugely different. But then after the 2000s, we start to see a very rapid increase in male cases of syphilis. The females have delayed a lot. And in fact, if you actually look at what sexual behaviors are in different populations who are positive for syphilis, you can see we have consistently been, since the 2013 here, shown here, it's consistently been in men who have sex with men. And that's what we've usually said is that's who needs to be screened, men who have sex with men. But if you look at this, women used to be really low down there and they've shuffled up. And that's partially because if you look at the darker blue, men who have sex with women are also the proportion has gotten wider and wider. So we're moving from just having this infection in men who have sex with men to men who have sex with women and now into women. And so that has led to this kind of pattern where, again, we see the blues starting to get darker and darker as time goes on. Utah is still quite light. We just flip over to a little darker as time goes on, but we definitely are seeing it in women. This is our numbers again in Utah. We have males in teal and women in purple. You can see definitely this is still largely an infection in males, but we are getting more and more women infected over time. In fact, from 2013 to 2022, we had 4 times the rate of infections in females. So why this, I'm highlighting this specifically is because of the effect in infants. So women who are infected with syphilis have the possibility of transmitting it onto an infant while they're pregnant, and we can have congenital syphilis. Data from from throughout the U.S. Shows this very nice correlation. We see in the dark line is the number of women of reproductive age with syphilis. You can see it goes, and the same pattern happens with the number of congenital syphilis cases that we have in the United States. So we are definitely getting an increase in women that then transmits over to increase in congenital syphilis. And so unfortunately, the same pattern happens if we look at congenital syphilis cases in the United States. We see these go darker and darker with more and more cases. And again, Utah is a little behind, but we are not super far behind. If we look at our specific data, so happily, Utah had many years, probably about 5 years with 0 congenital syphilis cases in our state. Unfortunately, that trend stopped in 2018. So this graph is intentionally left so that it doesn't have numbers because our numbers are small enough that they're considered identifiable, but the trend is obvious, right? You can see that we go from 0 to something pretty big recently. And in fact, the most recent year is 16. I can say that number because it's big enough. 16 cases is not what we want at all. And so we definitely are seeing this. And while we are seeing this, many other states are well ahead of us, and we're worried we're going to follow the trend that we will have many, many more cases in the next few years. So what are the risk factors for congenital syphilis? There's well-known risk factors. One is that you have sex with multiple partners, sex in conjunction with drug use, or transactional sex. One big one is late to prenatal care, so you don't get appropriately tested and treated. Then there's things like drug use, incarceration, and homelessness. These are, I mean, it's unfortunately true that this is true. This causes all sorts of infections, right? If we were to say what's the risk factors for hepatitis C, if we were to say the risk factors for any STI, a lot of these are the same. And it really is that behavioral complex that leads to poor care and then poor diagnosis and treatment, as well as exposure to the disease. So here in Utah, when we specifically look at our cases, we're able to do full evaluations of all those cases that occur. We found by far and away that we have almost all of them came in either very late to prenatal care or they did not come in until they delivered. So a lot of the cases are not a failure at all as us as a healthcare system, other than that we don't get women into prenatal care as early as possible. A lot of these women were recent arrivals to Utah. Many of them are coming from states with higher syphilis rates than us, and so therefore were exposed there and came here. A number of them also were from other countries where they don't have screening approaches, so therefore just were never screened. We do have a few that came in, were diagnosed, and then just never came back to get their treatment, and then went on to have the baby months later that had the infection. When we look at CDC's numbers, this is actually pretty similar to what we're seeing. So they have cases here, 3,700 cases. When they looked at what led to these cases, they found that 37% of them did not have any testing when they should have had testing. So a third automatically never were detected. Interestingly, 58% of them did have testing done appropriately. but 19% of them doesn't have any documented treatment at all. And then 69% of them had treatment, but it was not the appropriate treatment. So they didn't get the full treatment they should have. That did leave 12% who did get the treatment. And interestingly, there are actually a few cases here. So there was, 129 cases who got actually completely appropriate treatment and yet still went on to get congenital syphilis, which to me means we need to reconsider exactly what our treatment algorithm is. I know Dr. Pavia feels this way too. He has been in many conversations about this as well. But it does show Utah actually follows this a fair bit. I would say actually our no documented timely testing is probably would be a higher proportion of our cases than what the national data shows. So what are the challenges to stopping syphilis? Not just syphilis, but congenital syphilis, all of them together. And when CDC looks through the data they have on their syphilis cases, they find a number of things. So first, the people who have syphilis have a large percentage, report a large percentage of anonymous sex partners. You can see here that we have about 20% of our female syphilis cases reporting anonymous sex partners, going all the way up to 60% for men who have sex with men. This is a problem because then we can't get their partners treated, right? And so that just continues it. Very high rates of incarceration. So here I thought it was quite interesting that men with syphilis who men sex with men, they have a very low rate of incarceration, and that's because it's being transmitted in the community, not so much related to incarceration. Whereas for men who have sex with women and women, it is a large risk factor if you're incarcerated that you will be infected. We are seeing a increase in the rate of late diagnoses. So if you look at the end there, that gray bar that spikes up is people who have unknown or late diagnosis. So that means they've been going around for a while with syphilis and therefore are present an option to be transmitting for many, many people. And then this is an interesting one as well, that green bar at the end, we see that we get more and more women going in and getting diagnosed at non-STD clinics. So historically, we know that people tended to go to STD clinics when they had STD type problems, were diagnosed there. So those clinics have that in mind. They're good at it. They do it automatically, whereas non-STD clinics don't do these testing algorithms quite as cleanly and therefore are more likely to miss them. And so as more people present into those kind of places, we're more likely to miss it. So what is being done to affect this? Well, first there was a big announcement back in April. So ACOG, the American College of Obstetricians and Gynecologists, updated their recommendations of when pregnant people should be screened. So it has been for many, many, many years that there should be screening at the very first prenatal visit, and that was it, unless there were increased risk factors. I think over time we've all realized it's really hard to identify increased risk factors because people just don't tell you what their behaviors are. They deny risky behaviors. So therefore people weren't getting tested who could be exposed during their pregnancy. So ACOG now recommends testing of pregnant people at their first prenatal visit, during the third trimester, and at birth. And so this is hoping to catch these people who are infected during their pregnancy and make sure that they are not missed and not treated. So what is Utah doing? So we have a number of actions. I'm going to highlight a few here. One is that we have created a log where we have local health departments and federally qualified health centers who can do low-cost treatment. So if you ever see patients who need access to low-cost treatment, we have a log of all that. We also are trying to get Bicillin, or we have Bicillin on hand that we can give to clinicians. We know that one of the problems I mentioned earlier is that there's some people who come in and get diagnosed, but they don't get treatment because they don't come back. So our recommendation is you have treatment on hand so you can give them a shot right while they're there. We know for some clinics that's really hard to do. Either they have a very low patient population or they just don't have the money to do that. So we've actually ordered a small stock of Bicillin so we can give clinics this medicine for those patients. It is funded under a grant that only allows it to give it to people who can't afford the treatment. So we can't give it out broadly, but we can give it for very select cases. So again, at the end, I'll bring up this QR code in case you want to know how to reach out to our department to access some of that Bicillin. We are trying to improve access to prenatal care. This is a huge one, right? If we could get access to prenatal care to all women, it would affect not just congenital syphilis, but so many things. And it also is super, super complex, but we are trying to make some small steps here. We have community health workers that were people hired for different communities throughout Utah that represent sort of the underrepresented people in our communities. And they represent those people. So for example, we have a number of them in the Pacific Island communities who are Pacific Islander themselves, are sort of leaders in the communities, and therefore are really good spokespeople into those communities. And so we're working with all these community health workers to get them to talk to their communities about prenatal care, make sure they know where people can access care and get them there. And then an example is Davis County, their health department has added training about syphilis screening to their WIC program to make sure that there's some awareness there. And that's something we want to see how well that works and if we should do it other places too. And then we are trying to educate. I mean, one is right here. I'm trying to educate clinicians about the importance of screening, but also we're trying to encourage use of doxycycline when bicillin is not available. A few months ago, there was a national shortage of bicillin. It did not seem to hit Utah that badly, but it is just important for people to recognize if for some reason they can't get bicillin, doxycycline is an appropriate treatment. We also did recognize another issue is that clinicians had a hard time knowing if somebody was treated at another site or not. And so we now have it so that our staff at the department can look up treatment if you call us to see if we can find treatment at any other site. So if you have a patient come in, you're not sure if she was treated somewhere else, you can call us and we can see if there's any documented treatment. And then also we have funded the Utah AIDS and Education Training Center. They do a number of different trainings for us, but they one-on-one sessions where they can evaluate your approach and sort of consider if your clinic needs help in different ways to deal with this. So Dr. Merzak is somebody you could certainly reach out to if you're interested. And then overall, if we want to decrease congenital syphilis, we really need to work to decrease overall syphilis. One thing we would like to talk to more places with is getting STI screening in ERs for people who don't access care other places. We know that a lot of people don't come in for routine care. There's people who are either aren't insured, don't have social stability, whatever reason, they only come in when things are an emergency. And so therefore their one place to ever be seen is the emergency room. So we would really like to work with emergency rooms to see if they could do STI screening on those people who don't seek other care. So yeah, what can all of you now do as clinicians? Well, one, the obvious one is try to prevent this, talk about STIs, talk about risk factors. I know this is something everybody does, but just to put it back in your mind, discuss ways to prevent it. We also would love to have people think again about detecting. I know that for a long time, sort of in the general population, STI screen was GC, right? Gonorrhea and chlamydia. And as syphilis wasn't that common to screen for, we want to have people start thinking a little bit more actively about screening for syphilis, especially in those people who have any history of STIs. Or those people with all these social factors that would put them at risk, including homelessness, IV drug use, or incarceration. So really put that back on the list of what to consider. And then consider screening people who are using ERs or urgent cares as their only care site. And then treatments, as I said, if possible, try to stock bicillin in your clinic so that you can treat somebody before they walk out the door and don't come back. And again, treating more the general population and make sure we get treatment into people whenever possible. So that is my quick overview of syphilis. And quickly, I feel bad neglecting chronic disease. So I always have to do a chronic disease one. And I felt like since I'm at children's, I should do asthma. And I have to say, actually, the data is very interesting because after I made this, I'm like, asthma, child's disease. And you'll see as the data goes by, maybe this isn't just for children's. This is for everybody. Asthma is certainly, we all know, super common. We have more than 20 million people in the United States with asthma. This represents 9% of the population, so very common. If we look at Utah, we pretty well matched that. 11% of our adults have asthma and 7% of our children. So that means over 200,000 adults and almost 70,000 children in Utah have asthma. This is common. If we look at the prevalence by state, first, if we look at kids, Utah's doing pretty well. We're not quite the lowest level, but we're the second to lowest, so we're not super high in our asthma. But what I found interesting is if we look at the adult side, we're actually the highest. I asked my asthma team why that was, and they didn't have an answer, and I don't know why, but I thought that was very interesting that we actually do pretty well with prevalence in kids, but do terribly in adults. And I'll have to think about that more, but not sure what that is, but certainly something to be aware of. So what are the factors related to asthma prevalence? So this is national data. If we look at it, in blue is the men and in yellow is the women. I find it quite interesting. If you look at those young ages, it's a lot more men. If you look at the older ages, it's a lot more women. So it shifts sex as people age about how many people have asthma. We definitely know throughout the whole country that we have health disparities in this in terms of race ethnicity. This is from CDC, just showing that the non-Hispanic Black population has quite a much higher rate of asthma than the white non-Hispanic white. And we also see a really significant impact of income. So this is going from least impoverished to most impoverished along here, and you can see our prevalence of asthma goes up along it. And for Utah, it really is almost identical. We see the same thing. I didn't include the kids on this one, but it goes from little boys having asthma to adult women having asthma. Interestingly, for our race ethnicity, we don't see a huge difference actually in our minority populations there, other than that the Asian population has a lower rate of asthma. I think a larger part of this is probably due to small sample size. This is survey based, so we actually have a small number. I'll show you this again in another minute, and it's actually quite interesting what I can show you in a minute. But otherwise, on the income, it's actually, unfortunately, I put it the opposite way, but it's going from least poor to most poor this way. So again, same thing, as you get poorer, you get more asthma. So Utah really does reflect the rest of the country. We can't see such in our race ethnicity, but it does look a lot similar. So of course, asthma can be controlled. We have really quite good drugs these days for asthma, and it should be a really limited disease. So it's not just whether or not you have an asthma that we should care about. It's whether or not you're taking care of your asthma. So nationally, they've been able to track the percent of people who report having an attack in a year, which is a failure, right? And you can see we've gotten better. We were up around the 60s for both kids and adults. In 2001, and we're down around 40 in 2021. So we're improving, not maybe as fast as we all like, but we're improving. But really the big indicator is emergency room use. So the last two things I've said to you, both the prevalence of asthma and the asthma attacks, that reflects people telling us things. But what we really can look at is ED visits, right? ED visits, we can actually screen, see how many people are coming in for these things and see how well it's doing. So if we look at Utah, unfortunately, we don't seem to be changing much. We're about, so this is rate per 100,000 or 10,000 people. So about 20 per 10,000 people have been coming in for asthma visits in the ED since 2015 to 2022. So really not changing much there. And again, it's a clear impact with our race ethnicity, with our age and sex. So you can see our little kids, it's mostly boys coming in blue, and our adults, it's mostly women coming in yellow. So we see sort of the same pattern in who says they have asthma and who comes into the emergency room as asthma for that one. But then interestingly, race ethnicity. So I'm going to actually pull up. So this down here in the corner is what people say they have asthma. And up there is the people who come into the emergency room for asthma. And what you can see is there is a huge difference in the last bar is white. We say white sort of stays stable. You can see our Native Hawaiian Pacific Islanders come in a huge amount for their asthma, yet they weren't saying they had it very much at all. And the same for Black and American Indian, Alaska Native. They're using the emergency room for asthma quite a lot, even though it's reported to be quite uncommon in this community. I mean, certainly the reasons for that are super multifactorial. Probably they don't recognize that they have a disease, and so they aren't reporting it when surveyed. But it's also probably a large part about health access, right? A lot of these people don't have great access, so therefore they don't have controller meds. So they get more flares and have to come into the emergency room. And there's certainly the factor that there's a number of people coming in to the ED as their primary care site. So this is, I think, a really striking disparity that we need to think about how to address in Utah, and certainly something that my department is hoping to work on. And then finally, unfortunately, the last outcome of this is deaths due to asthma. You can see we are doing better. This is from 2001 to 2021. This is all the US, not just here. You see that blue line, which is the rate of asthma deaths. It is coming down. There's a blip in 2020 because of the pandemic, but we are definitely coming down. So that is hopeful. And when we look at us compared to other states, we are actually in the lowest category of deaths due to asthma in the US, but that doesn't mean it's all great, right? So if I actually pull up the specific numbers of asthma in Utah, in 2022, we had 4,000 adults and 2,000, almost 3,000 children had an ED visit for asthma in our state. We had 413 adults and 600 kids hospitalized for asthma, and we had 26 people die of asthma in our state. So this is really sad for something that we have great meds for and we really can improve. So what do we need to do to improve? So some ideas that I think a lot of places have implemented, but just want to put it out there in case some places haven't. We should take advantage of our technology. We all have fun things in our hands and our pockets. We should use them. So EMRs, electronic medical records, we should make sure they put up automatic reminders to ask about control, to ask about meds, to review exactly how well medicine is working and what treatments are needed. We know that technology reminders for patients work really well. Make sure that they do put in reminders so that they're taking their controller meds every day. Working on joint decision-making, getting buy-in from people. We really do need to work on talking to people, setting their goals, making sure they believe in the goals. I found it very interesting that a number of studies have been done looking at how well people think they're controlled. And it turns out about 30 to 60% of people think they're great control, even though they have asthma attacks, even though they have to take the rescue meds all the time, even though they aren't doing everything exactly they want. They have these misperception of what control really means. And I think that is something to talk to your patient about, that no, you should be able to do everything you want. You should be able to not have to take your inhaler all the time. And we need to get there with you and reset their goals of what they really should be doing. And then I do think we need to not ignore the adults. This was what surprised me. So in Utah, only 23% of adults report having an asthma action plan versus 42% of kids. And I know as a pediatrician, that was one thing you definitely had to click off, that it was required. And that's something we need to get back into the norm of for adult populations too. 32% of adults have uncontrolled asthma versus 20% of kids. And interestingly, 15% of adults say cost is a barrier to medication versus 8% of kids. And of course, that's partially related to insurance, but there's other factors there too. So we really should recognize cost as a barrier. The Allergy and Asthma Foundation of America did surveys. And if you look here at the results, the number one reason why the person did not take their prescribed treatment is because of they could not afford it. This is quite concerning. So when you're thinking about what you're giving your patients, try to consider generic meds. There are specific inhalers that have agreed to a $35 a month cap. So you can go onto the the Asthma and Allergy Foundation's website and find those meds so that you make sure you give that kind of med to your patients so they can afford it. And then there's also two different organizations that have a full list of meds where they can get lower cost meds and no cost meds options. So if you want to look at those sites to see if there's anything that can help your patients. And then I think last is some resources we have at the state. So we have a home visiting program where we do go out and evaluate homes to see what could be triggers. This is in Salt Lake County and Utah County. Other places really want it. If you complain enough, maybe we can make it happen for you. But this is something that you really could utilize for some of your patients to help them identify triggers. So it will come back as influenza A. And if we see it where there's types that are non-typable, that will definitely go to us automatically. It will go to the public health lab and we'll sequence it. For most of them that are A, we won't, but it would be included in that subset that we're setting the CDC for subtyping. Yeah. So Dr. Pavia just clarified that for Intermountain and the U, the test panel will identify A and subtypable, but some of the other clinics that aren't in those systems will not be able to detect that. Yeah. Okay. People want the surprise. So public health, it is the rumor, and it is so true that everything comes in at Friday at 4 p.m. I know in clinics this also happened, but I feel like in public health it's even more extreme because then you have to try to contact the clinic and everybody's gone home and there's no way to do it. So this one is quite interesting. So on June 7th, the FDA reached out to us about 8 poisonings that appeared to be related to the birthday cake chocolate bar from Diamond Shrooms. They contacted us because they thought there was a Utah, it was one of these 8 residents. It turns out actually that wasn't quite right. It was a Nevada resident who came, I believe, to Intermountain, I'm not sure, one of our 2 healthcare systems. And so it was treated here. So they saw it come up in our system instead of in Nevada. But I mean, we got to hear about it. So these patients were pretty significantly ill. They all had things like seizures, CNS depression. They were in the ICU. They were very, very sick. And I'm like, wow, that's really weird. What is this? And so I why chocolate? So I look it up. And it turns out Diamond Shrooms, and I'm saying it, you should really say it, Shrooms, is a microdosing chocolate bar. And I was like, yeah, exactly. I was, what? And if you go and look on this, I love the description, looking for that feel-good goodie that reminds you of your younger days. Remember those, right? You wake up, you're feeling electric. Well, anyway, it's supposed to be microdosing. And then they even give you some instructions of how many doses you need to take to be able to have the high that you want. And I'm like, how is this legal? It's on the website. It's made in California. And it's so you can buy it anywhere in the country. And I was like, just how is this ever possible? Interestingly, if you then go to the website and pull down their menu about what exactly is in these bars, it actually says these do not have any, let's see, what does it say? It doesn't have any, there's no presence of psilocybin, amantane, or any scheduled drugs. So they're selling this as microdosing, but then they say they don't have the Schedule 1 drugs that are known to be what magic mushrooms would include. So it's interesting. They're advertising it as magic mushroom microdosing, but then their like disclaimer says there's no actual chemical in it. But these people are having seizures and going to the ICU, so there's something in them, right? So that's how it started. And since then, as of, I think the FDA updated their website most recently on the 25th, there's been now 39 cases. There's been a variety of states. We still have not had one. 23 of the 39 cases have been hospitalized. Interestingly, FDA has reached out to this company and asked them to do a voluntary recall, which is always the first step. We try to get the companies to take things back. But the company is not responding and has not agreed to do this, which I thought is quite dramatic when you've caused 23 people to go into the hospital. And then finally this week, the results came out from FDA just went and bought the chocolate off the shelves in a number of states. And they did tests on them and they did find these chemical substances. Now, to me, those mean almost nothing. But it turns out that first one on the list is actually a derived version of psilocybin. So it's a modified version. So it's essentially magic mushroom that's a little bit modified. So there is definitely toxic chemicals in these chocolate bars. So what makes this exciting to us, or it could be exciting to us, is these are in Utah. We actually went out and looked. They are in a number of our shops. It's usually in the shops that sell CBD or Kratom, both of which are both quite scary. So really we are trying to advertise and make sure people don't eat these, they've actually now found it not just in the chocolate, but a number of these products from this company has these toxins. So just one of those weird things that you never thought you'd be researching chocolate bars that you get to do on a Friday. And so if anybody does see something like this that they're worried about, please reach out to us and let us know. So with that, I will thank everybody and pull up the QR codes. So in case anybody wants to sign up for the things, and I'm happy to take any questions, even though it is very close to the end. Yeah. So it's for people online. Dr. Purvia is asking about how do we get access to people who, because so many of these conditions that I've talked about today and so many other public health conditions are really a lack of access, and how we do this better. And I mean, partially it's this. This is my second time doing a public health grand rounds. My goal is to try to connect better with clinicians. And I think it is getting more of these discussions together is one of the very first steps. I think unfortunately it's so much about reimbursement, right? Like we have to find ways to make making sure everybody can access healthcare financially worth it to our clinical providers. And so I do think a lot of it, we need to consider how we can reform our reimbursement systems. Can we put in Medicaid approaches that are more encouraging these? I think like federally qualified health centers are meant to fill those gaps, but that's a huge burden for those sites. And so to think of ways to get our other health centers to work with them or work as in those sites also were really valuable. I think a lot of it still also is a lot of people just not even, a lot of communities not wanting to come to it. So making sure we have our health providers reflect our communities is so valuable. You always hear, for example, the LGBTQ community, they find so many people say very negative things to them based on their sexual behaviors and they don't feel accepted. So trying to get our providers to be more accepting, that would help too, or be more diverse also, right?
So, what are the other ramifications for a chocolate company like that? Can they be legally
Can't
held
hear.
liable and required to shut down?
So I will say with the chocolate company question, so this actually this will be FDA's realm, not public health, like the state public health, since it is one, it's across so many states, and two, FDA is the one who regulates what's actually allowable in food. I know the frustration of being, I've worked in federal government, frustration of being is that you have these, the ability to shut things down, but it takes a long time. Usually most companies, when something like this happens, will do recalls because they're liable right now, right? All those people in the ICU could very easily sue them for whatever damages. So usually the companies will choose to shut down themselves. This one appears not to be. So FDA is going to have to go through the whole court process to shut them down. They should be able to do it now that they have documentation. But interestingly, their website still says they have not. But then somebody else in the room was asking about, you said there was a grant. I'll just repeat that. So for people who are online, so this is a continuation of the discussion of how to get healthcare to people who are not accessing it or who don't have access, that there is a grant specifically to get children CHIP who are undocumented, but so much of the fear about being undocumented and coming forward and being possibly arrested for undocumentation or all the other things keeps them from using it. And we need to get better at telling it. Yeah, we really do need to get better connection. And that's one where like, I do think community health workers are a great way forward. We need to think about how to continue using them because if you hear it from somebody you know because you know them at church or you know them because they're in your basketball team and they are part of your community, I think it's so much more likely to actually get you to believe it and work on it. And I think that's a great system we've started with largely with the pandemic and we need to keep it. Yeah. So is somebody in the room suggesting that we do an ethics grand round about how to deal with possible legal ramifications of not getting full syphilis treatment? I know there's a lot of debate about that and how well does it work for decreasing substance use disorder or does it just keep people out of care? And I think it would be an interesting ethics discussion. You're right. Yeah. Well, thank you, everybody. And certainly I'm happy to hear any suggestions of what in-person site I should use next. We did children's first just because they were easy to volunteer, but I'd be happy to do this at different sites around the state and just as an excuse to meet people. So hope you all have a wonderful day and thank you.